Hi, my name is Connie Kleines and you're watching a video on the management of intermittent exotropia. Now, generally we prescribe treatment for patients with an intermittent exotropia when the patient has issues controlling the deviation. So if you have an intermittent exotropia but it's relatively well controlled, you may consider no treatment. However, should the patient be losing control or have poor control, this is where you would start to consider prescribing treatment for the patient. Now remember that treatment requires a high level of motivation and maturity. So the younger the child is, the less likely it is that you'll be able to prescribe any type of treatment such as orthoptics. The only options in the younger children are really treatment methods such as glasses and surgery, which we'll talk about in a moment. In relation to the treatments that we provide, what we're trying to do, particularly with orthoptics, is improve the control of the deviation and improve convergence function if that is an issue. And this will often be an issue with your convergence weakness patients and can become an issue with your divergence excess patients if they begin to deteriorate. Even when we operate on these patients or we perform surgery on these patients, again what we're doing is we're trying to reduce the size of the deviation there so that the patient can have BSV and control of that deviation. So in all aspects we're aiming for a good functional outcome for these patients where they are aligned more of the time and hopefully all of the time. Okay, now in order to discuss the treatment options we have in intermittent exotropia, what I'll do is take you through the GOODS acronym. So the treatment options that we have in that order in terms of glasses, occlusion, etc. And where relevant, I'll mention how it may differ, or the treatment may differ, depending on the classification of the intermittent exotropia. Let's start off with the optical correction of patients. So as I always indicate, go back to the principles of managing patients with exodeviations and manage them accordingly. Now, one of the options has always been to overcorrect the minus lens of patients with an exodeviation. It is particularly notable that the patients who best respond to overcorrection of minus, which is also called minus lens treatment, are patients with a divergence excess exotropia with a high ACA ratio. And the reason is that you can imagine that when you're putting the glasses on the patient and you're inducing accommodation through overcorrection, that with every diopter of accommodation extra that patient is doing, they're getting more of an effect in relation to the accommodative convergence because of their high ACA ratio. So in reality, an overcorrection of myopia isn't best for everyone. It is particularly useful in patients with a high ACA ratio. Moving on to occlusion. Occlusion you'll need to prescribe if amblyopia is present. Now, as we mentioned in the earlier video, generally speaking, divergence excess XT patients and convergence weakness XT patients don't tend to have amblyopia because they have a distance at which they are controlled and thereby develop relatively equal and good VA. However, your basic deviations, where they're intermittent both at near and distance, they are at a higher risk of amblyopia, in which case they're the more likely group that you will need to occlude. However, you'll always be doing visual acuity in these patients, and if you detect any amblyopia, immediately you go to occluding the patient to treat any loss of visual acuity. Now, in the past, there has been some suggestion that specifically for the condition of divergence excess exotropia, that alternating occlusion may be a treatment method. The reason is that with divergence excess XTs, they develop fairly dense suppression. And the thought is that if you alternate the occlusion, you may prevent that suppression developing and thereby preserve the patient's capacity for BSV. It's rarely prescribed in Australia, but you may come across clinicians who do advocate for alternating occlusion in divergence excess XT, so it's worth knowing that that may be an option. there is some evidence to suggest that this treatment, by reducing the suppression, can also improve fusional amplitudes and the motor control of the deviation. Moving now on to orthoptics. As I mentioned earlier, you're going to have to be selective with the patients you prescribe this to, as they're going to have to be motivated and mature enough to be able to undertake these exercises. Also, they don't work well with large deviations, so you're looking at the patients who are best going to respond to orthoptics are those with up to about 15 to 20 diopter deviations. Now, some patients obviously will be suppressed when they become XT. So your convergence XT patients, for instance, some of those will become XT at near. And in order for you then to progress into giving that patient orthoptic exercises, you must anti-suppress them. The same goes for divergence XS-XT. When they become XT, they suppress, and therefore if you're going to do orthoptic exercise, you must get rid of the suppression. The issue is that anti-suppression works much better in convergence weakness, exotropia, as compared to divergence excess. The divergence excess patients tend to develop quite dense suppression, and it may be almost impossible for you to anti-suppress that patient to progress to orthoptics. It's also worth noting that we can prescribe anti-suppression pre-operatively just before the patient has surgery. And the reason we do this is that if the patient has a residual deviation post-operatively or an overcorrection, so a consecutive deviation, if they end up having that small deviation post-op, if you've anti-suppressed them pre-operatively, they'll appreciate diplopia, which is clearly an incentive for BSV. So this is also worthwhile considering in patients who you think may not achieve BSV post-operatively due to their suppression. And then I've listed some other exercises that you may give your patients, convergence exercises if your patient has issues with convergence, and then fusional convergence if the positive fusion range is reduced. We could also look at relative fusional divergences, so stereograms in the cross position. And then finally there I've indicated base-in prisms, which are best used if you want to give the patient BSV to then build on their binocular functions, and once you've built their binocular functions, then reduce the base-in prism and wean them off wearing the prism. Now let's move on to surgery. Generally, surgery is performed if conservative treatments have not been effective, or if the patient is at high risk of losing BSV. So these are patients who are slowly becoming more and more frequently manifest, and therefore edging towards becoming a constant deviation. And what we want to prevent these patients from doing is suppressing constantly and thereby losing their BSV. Now, the type of surgery will clearly be dependent on the type of strabismus present. So go back to your principles of how to manage strabismus, and you'll be able to determine what surgery is required. So for a basic deviation where the deviation is very similar near and far, obviously we go for a unilateral surgery. For a convergence weakness exotropia, what we do here is bimedial rectus resections, so we strengthen the medial recti. I've also listed there a variation of the bimedial rectus resection procedure, whereby surgeons may add a slanting of the muscles if they want to have an effect that's greater in down gaze. Okay, and finally with the divergence XS-XT, well, this will be dependent on the subclassification of this condition, and is actually the condition where much of the debate around surgery or surgical intervention exists. So I'm going to deal with this separately in the next several slides and focus on the debates regarding the surgical intervention of intermittent divergence XS-XT. Okay, so the three main issues that are debated with regards to surgical intervention of this condition are, one, the timing of the surgery. So when should you operate? Early, when the child is very young, or later when they're older. The type of surgery, so unilateral versus bilateral surgery, and the amount of surgery. Should we aim for full correction or overcorrection? And what I've given you there is a quote by Knapp, which indicates that the choice of treatment is between surgery and simple procrastination. So with these children with divergence excess XT, what you will often do is either perform surgery early or, as Knapp says, procrastinate, wait and wait and wait and watch to see if improvement occurs. So in terms of timing, we're debating whether we do early or late surgery. Now, the advocates of early surgery indicate that if you go in early, then sensory anomalies such as suppression and ARC may be prevented, and you're going to address the patient's cosmesis much sooner than leaving a child with a potentially uncosmetic intermittent XT at school and so forth. However, the risk of going in early is that you may develop a esotropia, or the patient may develop an esotropia, in which case the esotropia will generally be constant, suppression will develop, amblyopia will develop, and then you have a new issue that you didn't have whilst the patient had an intermittent XT and BSV. So the advantages of delayed surgery is that you can wait and watch and see whether the patient will simply improve over time. And we know that the natural history is variable and that some children will improve over time. The other advantage of going in later is that as a child becomes older, your measurements become more accurate. So what you operate on, or the size of the deviation you operate on, will be more accurate. Also, as the child gets older, you have an opportunity to prescribe orthoptic treatment, which may assist the patient to control the deviation, which cannot be done when the patient is very young. And finally, as I mentioned earlier, one of the risks of going in early is creating a overcorrection and an esotropia. And when the patient is young, if they can't take control of that deviation, they will flip into suppression fairly quickly. And then we have the issue of amblyopia and the loss of BSV. So patients who operate on later are less likely to have persistent esotropias, amblyopia, etc. So given those arguments, most clinicians, not all but most, will generally operate later and just wait and watch to see what happens to this intermittent XT. However, they will go early if BSV is at risk, so if the deviation is becoming fairly frequent, and if the deviation is cosmetically very large and there's lots of concern around the cosmesis in terms of perhaps, kids are teasing the child, and or if the patient is experiencing significant number of symptoms, then surgery or early surgery may be advocated in those instances. Now, moving on to the debate around type of surgery, generally speaking, we will perform different surgery on the different types of subclassification of divergence excess XT. So for the patient with a true divergence XT, remember this is the patient where we can't explain why the deviation is smaller at near as compared to far. And therefore, we treat the patient as if we want to target the distance deviation more than near, because we don't know why that near deviation is smaller. So in this instance, we do bilateral lateral rectus recessions. However, for the pseudo-simulated divergence excess XT, we now know that it's the ACA ratio or TPF that's causing that deviation to be smaller at near. And we know that the deviation increases significantly when we occlude the patient or give them +3s at near. So what we do is operate on the patient as if they had a basic deviation. So what we're saying is these patients are essentially basic. They're not divergence excess XTs. The only reason that you're seeing them clinically as having a divergence excess XT is because they're utilising a high ACA ratio or TPF to dampen or reduce the size of the deviation and control it at near. Okay, so if we're going to treat them as basic deviations, then we're going to do a recess resect or unilateral surgery on these patients. The debate is whether we have that theory correct, and the jury is out as to whether we need to manage our patients in this way. However, for the purposes of this subject, I want you to learn that for the true divergence excess XT, we do bilateral surgery, And for the pseudo or simulated divergence XT, we'll do a recess reset. Okay, and the final debate is the amount of surgery. Should we fully correct the patient or should we over-correct the patient? Now, generally, most accept that the best outcome or the best surgical outcome is an overcorrection, because we know that over time these patients tend to have a recurrence of their XT. And as the patient gets older, we also have the natural divergence of the eyes. So if we can get them overcorrected and towards an ESO deviation, then they're more likely to maintain BSV for longer throughout their life. Now, to achieve an overcorrection, then the debate begins on what angle should we operate on in order to safely overcorrect the patient. And generally, you operate on the maximum angle that you find at greater than 6 meters. You could also operate on greater than 6 meters after post-occlusion. Now, post-occlusion, the exodeviation will generally increase at all distances because you've dissociated the patient and the eye has exodrifted under the occlusion. So, in operating on the post-occlusion greater than 6 centimeters, you're actually operating on the very maximum deviation. And you may find that this varies between clinicians as to whether they decide to take the maximum angle pre-occlusion or the maximum angle post-occlusion. I've made one other point there around lateral incompetence. Lateral incompetence means that the XT deviation differs in right gaze or left gaze as compared to primary position. And I mention that here because the surgeons need to consider any lateral incompetence, because these patients are at a high risk of developing significant overcorrection when they're operated on if they have this lateral incompetence. So just bear that in mind. If lateral incompetence is found, then surgery should be altered, and generally the recession amount is reduced in these patients to prevent significant overcorrections. Remember, yes, we want an overcorrection, but if we have a significant overcorrection that the patient cannot control, they will either have diplopia postoperatively, or if they're young, they will kick into suppression. Okay, and the last thing that I want to discuss is, given that we want to overcorrect these patients, what do we do if the patient returns postoperatively and doesn't actually achieve BSV, so they're experiencing diplopia? Well, it's a good idea that if the size is relatively small, so around 10 diopters, then you can leave them for a couple of weeks and ask them to try and make that diplopic image 1, in which case they may return and after several days or so achieve BSV. You may, however, need to assist the patient by giving them prisms. So you can give them base out prisms, give the patient BSV, give them orthoptic exercises, build their fusional divergence now because they're ET, and thereby assist the patient in controlling the deviation and then wean them off the prism. Another option is Botox, where you inject the medial rectus, give the patient BSV, and then hopefully they'll lock into having BSV as the Botox wears off. If, on the other hand, you have an undercorrection or full correction, again, you could prescribe orthoptics in these patients to either assist them to regain binocular single vision or to help them maintain binocular single vision. Okay, and finally, if the patient cannot regain BSV post-operatively, you may need to consider a reoperation in these instances. Okay, that brings us to the conclusion of this video. Thank you for watching.